you to know that, well, I'll get to it. This is such an interesting topic for me. I just love it. So what we're going to basically talk about is what are unusual experiences, how common are they, when do they cause problems, what causes that in the brain, what happens in the brain that makes our brain do what our clients' brains do, and what can we do about it? So we know that hallucinations are sensory experiences that are experienced by the person having them, but not by others. There's a distorted self experience. This is kind of interesting because I've done a little bit of a presentation on a differential diagnosis, and there's actually a thing called self disorders, which is disorders of self is the way that they frame it. And it's actually a different thing than schizophrenia or psychosis. It kind of comes alongside of it sometimes. And that disorder of self is an experience of just having yourself kind of evaporate, like there's no boundaries between you and the rest of the world. Ellen Sachs had a great description of that. She said she was like 8 or 9 years old, so it was quite earlier than when her symptoms showed up. She remembered feeling like being a sandcastle that was just being wiped away by the waves. That was what her experience was. So I thought that was kind of really cool that there's disorders of self that can run alongside psychosis. So there's that distorted first person experience, hard to put distance between self and others. You know, everything is, the relationships with everything that they have around them is changed. Things don't seem real. And of course, because of all of that dopamine stuff going on, things seem particularly important even when they're not. And so special meaning gets placed on those. And, you know, usually it's it leaves the person with a sense of fear, like something's going to happen to them. I know if I were in having those kinds of symptoms, I would have those kinds of fears as well. On top of that, these folks that we work with are nervous around others. They don't trust others. Don't trust the environment. So they withdraw and they don't talk about it because they kind of know that things are not right. So being around others and that nervousness that they experience is not as distressing as the symptoms themselves, is what we're given to understand. We know that these experiences begin in childhood or early adolescence. So I looked up some statistics about childhood unusual experiences. It turns out well over half of children 9 to 11 experience some kind of unusual experience, hearing their name called or hearing something that's not there, or seeing something that's not there objectively. 40 to 70% hear a voice at some point in time. That seems just, you know, more the norm than not. But most kids are not, they don't even worry about it, you know. They kind of hear it and it goes over. About 15% find them enough to be distressing. But of course, only 1 to 3% of people in the United States actually experience schizophrenia. So we know that amount of children who are distressed by those unusual experiences, those experiences don't follow through to adulthood with all of them, which makes sense when we look at the CHR, the clinical high risk data, that so many of them have unusual experiences, but not so many actually transition into schizophrenia. So things like hearing voices that others can't hear, you know, feeling like you're being followed, seeing things that other people couldn't see, feeling like you knew what another person was thinking, even though they weren't speaking. that there had been some change in their body that they just didn't understand, a feeling or a lump or a movement inside or a tickling. And some kids felt like they had some special powers. So I remember being, I think, 10 or 11 years old and being fascinated with witchcraft and buying one of those little tiny books at the checkout counter, you know, and trying it out and just feeling scared that I might have done something really horrible because I did that. So, you know, the imagination really carries us a lot when we're little. Of course, we have an unusual experience, and because we don't know what it is, and because the dopamine makes everything salient in our environment, we have to figure that out. And usually, because it's unusual and scary, we appraise it negatively. And so then we develop some belief about it. We go into the world with that negative belief bias, and then everything just gets reinforced over and over again. And we'll do, as you know, pretty much anything to cope with that. Foil over the ears, washing incessantly, being afraid to flush the toilet. I'm looking at Amy because she had a client like that. Really interesting ways to cope that just aren't terribly effective. So let's get on with finding out what the experience is all about. This is a wonderful little graph by Vandergag, who's a really interesting guy. And he talks about all of the places in the brain that are involved with voice hearing or delusions. So we have voice or a sound of some sort. It goes into the ear, it goes into the Wernicke area. If you remember, Wernicke's area is affected also by alcoholism. And when that begins to go, then people in late stage alcoholism begin to have hallucinations. So that fits. That information goes into Broca's spot in the brain, which has to do with generating voice. It goes into the prefrontal cortex, where we try to make sense of that. It goes into the ACC, back to Wernicke's area. And at some point, we hear a voice. But the ACC, this, what is that? Anterior Cingulate cortex is a place where we monitor, that monitors the sound coming in. And it erases things that, or disposes of things that just don't make sense, are kind of background noise, so on and so forth. When that's offline, there's no monitoring system going on. So when there's no monitoring system going on, the brain hears everything. And so everything becomes important. And that circuitry gets screwed up. And the voice then, or whatever it is that we're hearing, we can't figure out whether that's external or internal. And so that's one area of the brain that really gets affected. I wish I knew so much more about this, but I don't. It just fascinates me. So in delusions, we're looking at a big part here in the prefrontal cortex. You'll see over here, there's this thing called the mesolimbic pathway. That pathway is where dopamine gets released. And when, you know, healthy, normal people are walking around, we see an event happen, something catches our attention, we get a dopamine release, we try to make sense out of it, and we take action. We have feelings and emotions and the whole thing. One of the things that also goes wrong with people with schizophrenia is that pathway will release dopamine randomly. Nothing has to happen. And all of a sudden, everything becomes salient. So it may not be that some huge thing happened or some trigger occurred. It may be that the brain just randomly, you know, released a bunch of dopamine, and then the episode begins. So here's the prefrontal cortex. Now let me get my notes up here so I know that I'm reading all the right things here. This regulates the amygdala in the brain, which is somewhere back in here, and the nucleus accumbens, which is somewhere right up here. And it helps us with reality monitoring. When those places in the brain are disrupted, it's tough to make a distinction between reality and what's in imagination. And when there's a decline in this prefrontal cortex, there's a decline in spontaneous activity going on up here. That happens when, for people who have schizophrenia as well. It's just not as active, it's kind of depressed. All right, so when this prefrontal cortex is depressed or declining in activity, that results in hallucinations, okay? So we've got unusual activity going on here, and the prefrontal cortex is kind of depressed, less spontaneous activity that results in hallucinations. This little baby, the ventral tegmental area, a little tiny thing, is associated with negative symptoms. It's involved with motivation, emotion, learning, physiology, and the neurons in this area of the brain are shown to be of kind of irregular shape and size, as well as thickness, particularly with people who have schizophrenia of the disorganized type. So that can be affected as well. The nucleus accumbens it regulates the amygdala. Oh, wait a minute, this didn't go. I need my notes. What happened? What did I do? Okay, we did this, didn't we? For it to be the mess. Oh, okay, this nucleus accumbens is thought to be part of the mesolimbic system, the one that randomly deposits dopamine into the brain. So remember, when this part of the brain is depressed, this becomes overactive, and it becomes overactive with dopamine. And when that happens, the silly amygdala gets all excited and it goes into overdrive. Okay. Here's the amygdala. This has to do with emotion. And when that goes nuts, we have a very hard time figuring out what emotion we're having. If we're even having one, hard time to, oh my goodness, this is not working well. The amygdala gets overactive and starts not being able to regulate emotions at all, which we of course see in our clients. When the amygdala gets overly excited, it depresses this part again, okay? And so when that part gets depressed, we're gonna start having hallucinations. Now, this part is connected to the hippocampus. Do you guys remember what the hippocampus is all about? The hippocampus is all about learning and memory, right? Remember that? So the hippocampus gets out of whack. So because the hippocampus is involved, and that's involved with learning and memory, all the experiences that this person has had has now been learned by that hippocampus, right? That memory goes into the amygdala because the amygdala stores all the memories, right? And generalizes everything so that if you run into anything that's remotely similar to what you've experienced, that amygdala gets triggered, the emotions go offline, the prefrontal cortex gets depressed, and there we have it. We have a brain whose circuitry is all kind of screwy here. So we have an upregulation, and what we mean by that upregulation is a lot of dopamine coming into the system. and we have to reset it. So we have to downregulate this prefrontal cortex somehow to unlearn things. So this, with the amygdala working overtime, it's super, super hard to reset the brain. And the hippocampus has locked all this learning in as well. Okay. Now, all of this is a bunch of kind of looking like an electrical circuit map that nobody can understand, and I wouldn't expect anybody to remember all that. I barely hang on to it myself. However, I think this is kind of an important slide to look at since we're talking about neurology. Fmri images of the brain of somebody with schizophrenia before and after cognitive behavioral therapy for psychosis. So these folks were taking medicine but had residual symptoms. And so nothing was changed, but you can see here, well, there's not a whole lot going on the right-hand side, but the left-hand side, you can see there's all this activity going on before CBTp, and at follow-up, both the amygdala and the hippocampus showed a significant reduction in activity, which I thought was fascinating. So folks, if you ever think that your CBTp treatment is not working because it's going slow or there's only incremental progress being made, I want you to know that you change the brain of the people that you're working with. You really do. So I want you to keep that in mind, most importantly. So the amygdala and the hippocampus involved with emotional response and memory and learning. And these two pieces of the brain are really at the core of psychosis. Now, I want to tell you too, that what I've described here is only one path of activation in the brain. So we all know that people with schizophrenia, that population is very heterogeneous. It's just everybody has their own kind of schizophrenia. Everybody has their own kind of experience. So those pathways in the brain can be really varied. This is just one explanation, and probably the most common explanation for what people go through. There are other things that will create this kind of a pathway. We all have patients who have had antipsychotics that target dopamine, and they don't seem to have a reduction in symptoms. And that's because there may be another neurohormone in there causing problems. Glutamate has also been targeted for quite a long time now in the study of schizophrenia. And so I want to make sure that you know that what we've described is just a common way, but there are many ways. And sometimes we prescribe for schizophrenia and the medicine's just not working, and it's just because they have a different pathway or a different neurohormone causing those problems. The folks that we looked at with the brain images there were specifically first episode psychosis patients. So it really shows how if we catch this early, we can really do a lot of good with our work and our treatment. Also, the folks that did that study wanted to say, you know, anytime we study schizophrenia, there's a lot of polluting information unless you're sitting in an ivory tower somewhere. You know, anything that goes on the outside, the way medication reacts with the system, so on and so forth. But it was the first study that actually was able to get a functional MRI and pictures of the brain before and after CBTp. So know that for all of us, when we get stressed out, our dopamine shoots up and we get anxious. We get flooded with sounds. You know, all that happens to every one of us to a lesser or greater extent. And if you get anxious and stressed enough, that dopamine makes it just really hard to make a decision or move. And I know I have had those experiences, few and far between, thank God, but I've had those experiences where I've just been like solidly frozen in my place and don't know what to do. And so what we're looking at is a lot of stress for all of us, but particularly for the people that we work with. That stress is what drives all of that activation, or is one part of that. So certainly the stress bucket can help. Let's move on to this. So you're all familiar with the stress bucket, right? So we don't need to kind of do that activity, but all kinds of things can really help with stress, as you well know: yoga, meditation, grounding experiences, calling somebody for help or support, exercise, music, whatever it might be, playing an instrument, reading out loud. It could be a number of things to help reduce that stress. But stress reduction seems to be the thing that downregulates all that activity. And so if we can convince our patients to practice daily and to take care of themselves, gosh, if we could do that with ourselves, that would be great. But doing it with our clients would be a good start. So I'll go with that. So that is some brief information on how the brain gets affected by psychosis and schizophrenia, and what we can do about that, at least non-medication wise, and that can be a great help.